Hello, I'm Richard Orlandi, and I'm honored to be part of the Rhinology Worldwide video textbook. Today, we'll be discussing the burden of chronic rhinosinusitis and how we as clinicians can ease that burden. First, we'll start off understanding the societal and individual burdens of chronic rhinosinusitis. We'll discuss methods for addressing the large individual burden of chronic rhinosinusitis, and we'll determine effective methods for enhancing patient participation in and satisfaction with chronic rhinosinusitis treatment. But first, a question. Why did you want to go into medicine? Think about it for a second. What started you on this journey? This is one of my favorite paintings called The Doctor, painted by Luke Fildes. He was commissioned to paint a subject, anything that he wanted to, 13 years after the death of his son. He chose to paint this scene, reminding himself of the care that the physician gave to them in their extreme circumstances. Fildes' children later described his thinking on this painting. The character and bearing of their doctor throughout the time of their anxiety made a deep impression on my parents. Dr. Murray became a symbol of professional devotion, which would one day inspire the painting of The Doctor. 13 years after this event, Fildes was able to capture it. Remembering that feeling that you had going into medicine, I suspect it may look a little bit like that painting. Do you feel that same desire to selflessly serve others, that same fire burning within you today? If it's diminished a little bit, that's okay. It happens to all of us. But before we start tackling the burdens of chronic rhinosinusitis, let's talk about why it may be difficult to do so. Let me illustrate why I think this happens to all of us. Please allow me to symbolize this patient-clinician interaction like this. If only our interactions with our patients were this simple. Instead, we work in complex, nested systems. If we're not careful, the sacred patient-provider interaction can become lost. We have the productivity required to pay salaries and utilities. We need to work at the top of our license, meaning that we involve others in a patient's care, and that can dilute our interaction. We have billing, coding, and litigation worries, and that's just regular medicine. What about academic medicine with research, education, and administrative responsibilities? As we can see, there are many interactions which can complicate this one central interaction. What are some of the things, the pressures that we deal with that can impact that interaction? There are a few realities in medicine that can, they don't have to, but that can negatively impact that desire to serve, that can get in the way of our patient-clinician relationship. Taken to an extreme, these can lead us to see our patients as objects to a degree, not as our fellow human beings that we serve. Patients could be seen as units of work. How many cases do you have in the operating room today? How many RVUs do you need to produce this month to pay the staff and cover your expenses? Patients can become checkboxes. Checkboxes and checklists are great. They help us get things done and make sure we don't miss anything. But remember in our training when they were barriers to going home, seeing our family, or eating, or sleeping. In that case, when our patients become that, we may resent them. As I mentioned, patients can become units in a complex nested system, widgets in a factory. And in some of our academic pursuits, we don't even call them patients or humans, we call them subjects in research or in academics, in education. Now, we do this purposely to some degree, so we don't become overly involved and lose our objectivity. We don't talk about Mrs. Jones, the single parent and sole breadwinner of 3 with a life-threatening infection. Sometimes we put on a little armor, and instead we say the necrotizing fasciitis case in OR3. Now, we need to do that to some degree, but we have to be careful as we do that to not go too far. Automation is one thing that can help us, but it can create some problems for us. So, as I mentioned, we don't want to see our patients as widgets in a factory, but sometimes in a business sense, we have to employ some of those positive lessons. We can have increased throughput for more care for the same spend. We can reduce errors through reducing variability. The Toyota production system, the model for the world, bases its success on reducing variation to less than 6 standard deviations from the mean, the so-called 6 Sigma rule. Lessons from business can certainly improve our ability to provide cost-effective and cost-conscious services. But we need to ask ourselves, is medicine simply providing services? To provide a diagnosis and a treatment, or are there other aspects to it? Let's notice a significant difference between these two pictures. There's no people in the one on the right side. Now, the need for throughput and the need to reduce costs may no longer be a reasonable expectation for this picture. But we don't necessarily want this one either. How can we actually find the bridge between these two and maximize them? How can we find automation where it can facilitate and not diminish our interactions with our patients? At the University of Utah, where I practice and where I have administrative responsibilities, we've made significant progress in bending the cost curve. We've done this by holding ourselves to a strong but simple concept of value. The University of Utah value equation, which is an adaptation of others, is simply that value is quality and service over cost. It includes service, like our painting of the doctor. In this construct, controlling cost is only one dimension of the equation. Increasing quality or service are just as important as reducing costs. In fact, costs can even rise if quality and service rise even more, as this will generate an increase in value. Preventative care measures are a good example of this, where we invest dollars up front to have a downstream increase in quality. Now, pathways and algorithms can apply Lean and Six Sigma principles and can reduce error, duplication, and waste. These interventions can reduce costs and improve outcomes, positively affecting both the numerator and the denominator in our value equation. These can be helpful things. For instance, at our institution, we've applied these principles in our Rhinology clinic to efficiently increase enrolling patients in research while not interrupting our clinic flow. Some of the lower hanging fruit can be claimed by applying simple principles and practices. For advanced problems, system engineers can be valuable, and many health systems have them embedded within them. Another example is the electronic health record. It can both benefit and detract from patient care. Clearly, we have easy access to information, best practice alerts, to remind us of necessary tests and interventions like cancer screening and vaccinations. We can link patient messages and provider messages to healthcare records to facilitate accurate charting. But clearly, we all know that they can detract from patient-provider interaction. So many times I see a provider having the screen between herself and the patient, where it's literally a barrier between our patients and our clinicians. And clearly we know there's a ton of noise relative to the amount of meaningful signal in our current electronic health records. Clearly a lot more work to be done there. Machine learning can also be very helpful with large amounts of data. We have millions of patients with chronic rhinosinusitis, and we have millions and millions of data points about these patients. We have a lot of questions, and we need help finding the answers. How can we categorize our patients into ways of understanding them that we can figure out what's the best therapy for that individual patient. We know chronic rhinosinusitis is not just one condition. How can we understand the varieties, the endotypes of those conditions? And this is where machine learning can be very, very helpful. It can spot trends in data and postulate relationships that we can then test and refine with multiple iterative steps. It's certainly much faster than a human brain can do. So as we've seen, automation really has great potential to reduce error and reduce costs. It can help us to understand our patients better. It also has the potential to dehumanize our healing experience. Let's remember, healing is so much more than just accurately diagnosing a condition, finding the cause, and delivering a treatment. So we've identified some of the things that make this seem difficult, that can get in the way between a clinician and a provider. How can we apply what we've learned to chronic rhinosinusitis? One way to reclaim our empathy is to strive to put ourselves in our patient's shoes. That path to reclaimed empathy is to really understand what their burden is. We see our patients for a few minutes, and we try to help them with that burden, but they live it 24/7. What does that feel like? Well, let's start at a macro level with the direct societal burden of chronic rhinosinusitis. It's substantial. In 2014 dollars, $7 to $10 billion annually in care. And we also know that there's a significant indirect cost as well. In a study performed in 2007 by Neil Bhattacharya, we know that about $772 are spent on average for patients with chronic rhinosinusitis. Interestingly, $90 of those 2007 dollars were actually paid for out of the patient's pocket. It begins to give us a sense of what it's like for our patients. Now that $90 or that $772 pales in comparison to the concept of applying biologics to chronic rhinosinusitis. These are very expensive therapies annually. How long do we treat patients with monoclonal antibodies? Is there an endpoint, or can we predict what that will be, and for whom will monoclonal antibodies be most beneficial? What will be society's overall benefit, and can it outweigh the cost of these therapies, at least for some individuals? These are all very important questions that we're going to need to understand as we begin to apply these therapies, and certainly as we do it in large populations, not just a tertiary end of the road chronic rhinosinusitis patient who's exhausted all of her other resources. We need to make sure as we apply these more broadly that we know where they're going to be most beneficial, and a great deal of work still needs to be done around that. Now, I mentioned that there's a significant direct cost of chronic rhinosinusitis to society, but there are also large indirect costs, in fact, greater than the direct costs. Well, what are these? What makes chronic rhinosinusitis so expensive to society beyond the direct costs of seeing a provider, having a prescription, having a CAT scan, getting surgery, and so forth? One of the biggest costs is the loss of productivity, or the loss of days at work. On average, patients with chronic rhinosinusitis lose about 1 to 2 days of work due to chronic rhinosinusitis. Moreover, there's actually 73 million restricted days on top of the lost work days. So we have absenteeism, but then we also have presenteeism. What does that presenteeism look like? Well, studies have shown a reduction in activity, limitations in work, limitations in social interactions, and cognitive limitations that are associated with pain in chronic rhinosinusitis. And this is even worse for our patients who have the worst symptoms. A Canadian study looked at chronic rhinosinusitis patients who required surgery. In the 90 days prior to scheduling the surgery, to making the decision to go to surgery, 2.5 days were lost out of those 90 days. But in the time that it took between the decision to surgery and getting to surgery, in those 90 days, 6 days were lost from work, despite the most aggressive medical therapy. So we see that our patients who suffer the most have significant impacts in their ability to work and enjoy life outside of work, at home, and care for their children, care for their families. Why is that? Why is this burden so large? This is one of the first studies that really helped us to understand this. Glicklich and Metzen used the SF36 test to understand the patient's overall burden of disease. And when they looked at bodily pain scores and social functioning, they found that patients with chronic rhinosinusitis had worse bodily pain and social functioning compared to patients with congestive heart failure, chronic obstructive pulmonary disease, angina, and back pain. This was startling. This really gave us an insight into, wow, our patients are truly suffering. Now, that study, in a sense, was repeated, or at least similarly repeated, by Zach Soler, where they looked at utility scores for various health states. So a patient has a utility score from 0 to 1, 0 being death, 1 being perfect health. The average in the US is 0.81. And as we can see, chronic rhinosinusitis lands at about 0.65. But look what's around it. End-stage renal disease with hemodialysis, Parkinson's disease, coronary artery disease requiring angioplasty. These are the conditions that we think about what patients with these conditions are like and what their daily quality of life is like, how healthy they feel on a daily basis. And that's where our chronic rhinosinusitis patients are as well. When we actually start to look at the symptoms associated with chronic rhinosinusitis, we begin to understand this. Now, this is from the 1997 work by the Rhinosinusitis Task Force, and it shows what are called major and minor factors. The major factors in making a diagnosis are seen above, but look at some of these more minor factors, and particularly fatigue. Let's think about what it would be like to be fatigued all the time, not just to have these major factors that we can't escape on a day-to-day basis, but some of these minor ones as well. So let's look at fatigue. It's definitely part of the chronic rhinosinusitis burden. In this study, patients were asked about their level of fatigue, and what we see is where it was prior to surgery, at 9 months after surgery, and at 15 months after surgery. And we see that there's a lasting effect, an improvement in fatigue with an endoscopic sinus surgery intervention. Now, interestingly, notice that those with and without depression scored quite differently. We know that depression is also a significant part of the chronic rhinosinusitis burden. And it's probably underreported. The average in an American population is 5 to 10%, but in our patients with CRS, we see 9 to 26%. That 9% is a reported history, but up to a quarter will score in the moderate to severe range on depression screening. We know that depression is associated with more frequent physician visits, antibiotic use, and missed work days. There's a strong association between nasal-associated symptoms on the SNOT-22 and depression. Patients have worse pain, worse energy level, and difficulty with daily activities. And speaking of pain, there's an impact on pain perception. There's an increased awareness of physical symptoms with depression. And there's a tendency to be preoccupied with physical symptoms that otherwise wouldn't be a concern to someone without depression. And we know that patients have worse symptom scores than non-depressed patients preoperatively. This is a study done by Litvak and others that showed this, that when we look at depressed and non-depressed patients at quality of life, we can see that before surgery, they are very different. What's gratifying to see is that after surgery, they improve to the same degree. Unfortunately, the patients with depression still stay lower on a quality of life measure than where patients who were not depressed started out. This is a chronic rhinosinusitis specific quality of life measure. We can see improvements, but we don't get to the same level postoperatively with our patients with depression. But there is a glimmer of hope in this. This is a quote out of that study. In depressed patients with pre and postoperative scores, the severity of depression significantly improved postoperatively. Now, no one's going to say that endoscopic sinus surgery directly affects depression. But it's interesting to note that these patients, on average, drop to a PHQ-9 score of 6 when they started out greater than 10, which is the definition of depression. Now, these are some of the ways that our patients experience this burden of chronic rhinosinusitis, not just the rhinologic symptoms we think about, but the lost work, the lost productivity, the lost activity with their home or with their parent, with their family at home, the depression, the fatigue. So the big question, of course, is, well, endoscopic sinus surgery is a treatment for chronic rhinosinusitis. Is it worth it? It's expensive. We see that in these 2018 dollars. Is it worth it? Well, it requires us to create thresholds of value, to say what we're willing to spend for over a certain period of time, and what the outcome is that's worth that cost. Now, there are sophisticated algorithms to look at this. This is one of those. This is a study done by Rudnick et al., where we take a number of different machine-generated permutations and see where they end up on a willingness to pay versus an effectiveness. And then we say, okay, we're willing to pay this much. And in this case, it's $25,000. So if we're willing to pay $25,000 over the course of 30 years, is that sinus surgery strategy worth it? And in this case, there's a 74% certainty that it is. Now, we can change the willingness to pay threshold to $50,000, and it shifts that line a little bit more to the right, and we see in that bold line. But what this means is that the time horizon analysis here suggests that endoscopic sinus surgery becomes the cost-effective intervention within the 3rd year after surgery compared to medical therapy. Now, the Harvard group repeated this analysis with slightly different assumptions about effectiveness and demonstrated that 85% were effective at the $25,000 willingness to pay, and that 99% certainty that the ESS strategy was the most cost-effective option at a willingness to pay threshold of $50,000. So in a time of cost consciousness, the data indicate our patients are better off with endoscopic sinus surgery for chronic rhinosinusitis 74 to 99% of the time compared to failed medical therapy, depending on the willingness to pay and the outcome threshold. This means that we can actually now put in dollar amounts and in numerical amounts this value equation. We can begin to see how we can relieve the social and individual burden of chronic rhinosinusitis, and we can see how these therapies can be compared one with another, which brings us back to where we started. The challenges are significant economically and in other ways at a societal level, but let's remember why we do what we do. It's about this sacred interaction between healer and sufferer. We acknowledge the pressures that exist and their potential to affect this relationship, and we leverage the potential benefits that are out there for us, and we advocate and push back when the pressures can hurt our patients. And we continue to be what we set out to be. We continue to ask ourselves, how can we as clinicians, for that individual patient, and for all of our patients, begin to ease this substantial burden? Let me come up with a couple of ideas for you. First, Let's go back to that first question I asked you. Let's rediscover our why. I love this idea of patients coming second. I know it sounds heretical, but the idea in this book is if we don't take care of ourselves first and those around us as healthcare providers, we're not going to be able to take care of those around us as patients. We need to be strong enough, fueled enough to be able to lift others. So revitalize yourself, rediscover your why, fill up your tank. That may be with family and friends, that may be through exercise and health, it may be through nature or whatever refreshes and revitalizes you. For some, that may be a faith tradition. Interestingly, healing and lifting burdens are seen as divine attributes in many faith traditions, whether it be in the Old Testament, the Quran, the New Testament, or many other sacred texts. This idea that healing is a divine attribute, that we as clinicians have the opportunity to share in, hopefully that'll help us as we rediscover our why on a daily basis. Next, take that why and harness that motivation to create a patient-focused system in your practice and in everything you do. Remove barriers, maintain eye contact, actively listen, rephrase back to your patients so they know that you're hearing them. Sit when you see your patients so you don't look hurried. Involve patients in their decision-making. And I very much like to finish my visits by always asking this question. I used to ask, do you have any questions? But that's a test. This one is better. Do you have any concerns we haven't addressed? And if I've done my job in that visit, no, they don't. And if I haven't, then we're going to be able to discuss those. People are worried this will take, so much time and add so much to the visit. It doesn't, if we've done our job to take care of our patient and to support that sacred moment between clinician and patient. Also, rediscover your why. After rediscovering your why, create a patient-focused system that's a team approach. It shares support of the emotional burden of taking care of patients with CRS. It's hard on us, and it's okay to admit that. It's okay to share that burden with others, whether that be through patient education, with our staff helping out with that. It's critical that we're all aligned in seeing our patients as humans and responding that way to them, and that we're doing it efficiently so that we can provide as many services to as many patients that are suffering as possible. Lastly, innovate and standardize. Use that system to try new things. Make sure it's valuable to the patient. That's the outcome that matters. Use the Toyota production system, Six Sigma, etc. Find out ways to stay on time, to improve access for patients and other things. And then put it all together in a plan, do, study, and act cycle. Build systems that support one another, supporting a patient, taking care of ourselves, and taking care of others on our team. Finally, let me conclude. I hope we've learned about ourselves and about our patients and the burdens that they carry. I hope we've learned how we can ease that burden. Let me leave you with two final thoughts. There's a quote from Maimonides that has been my true north. May I never see the patient as anything but a fellow creature in pain. May I never consider him merely a vessel of disease. This has been the true north I've tried to live by in all of my decisions, in all of my interactions, both in my practice and in my administrative responsibilities. It's helped me to remember that we don't just treat conditions like chronic rhinosinusitis. We treat people with these conditions. Thank you for the opportunity to visit with you and to share these thoughts. If you do want to pursue this a little bit more, I would suggest two readings. The portion in the ICAR rhinosinusitis document that discusses the burden of disease, and any nonfiction, fiction, or religious text that reminds you how much you care about others.